Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Sustained Complete Responses in Lymphoma Patients Receiving Autologous Cytotoxic T lymphocytes Targeting Epstein-Barr Virus Latent Membrane Proteins by Catherine Ballard et al. My name is John Timmerman, and I am an Associate Professor of Medicine at the University of California, Los Angeles in Los Angeles, California, USA. My oncologic specialty is lymphoma. Decades-long efforts to stimulate cancer patients' immune systems to destroy their own tumor cells are now bearing fruit. It has long been known that tumor antigen-specific T cells, most commonly CD8-positive cytotoxic T lymphocytes, or CTL, can, under certain conditions, recognize peptides derived from protein tumor antigens bound to HLA molecules on the cancer cell surface, prompting a lethal attack. Nonetheless, in most cancer-bearing hosts, naturally existing tumor-specific T cells are not only insufficient in number, but their cytolytic capacity is weakened or turned off altogether by tumor-associated immune resistance mechanisms that have evolved within the tumor microenvironment. So how can the host T cells be mobilized to tip the balance towards clinically significant tumor immunity? For most human cancers, appropriate tumor antigens capable of eliciting T cell responses are not known, and for many antigens that have been described, immune responses against these targets are weak. However, virus-associated cancers have proved to be a valuable testing ground for the emerging field of adoptive T cell therapy, that is, growing a patient's T cells outside the body, then reinfusing the activated T cells once they have acquired potent cytolytic activity. Catherine Ballard and colleagues at the Baylor College of Medicine, the Methodist Hospital, and Texas Children's Hospital have studied adoptive T cell therapy of Hodgkin and non-Hodgkin lymphomas arising from Epstein-Barr virus-infected B cells for many years, and now report on sustained complete responses in lymphoma patients infused with autologous CTL targeting EBV-derived latent membrane proteins, or LMPs. Epstein-Barr virus, whose genome encodes nearly 100 proteins, can transform normal B cells in vitro into rapidly proliferating lymphoblasts. However, to evade the host immune response, infected tumor cells limit the expression of EBV antigens in one of three patterns of so-called latency. In type 1 latency, found in Burkitt lymphoma, only a single Epstein-Barr virus nuclear antigen, EBNA1, is expressed. In type 2 latency, found in Hodgkin's lymphoma, NK T-cell lymphoma, and some diffuse large B-cell lymphomas, the latent membrane proteins LMP1 and LMP2 are also expressed. And in severely immunocompromised hosts, post-transplant lymphoproliferative disease, or PTLD, or AIDS-related lymphomas can arise which express a greater number of immunogenic EBV target antigens in the type 3 latency pattern, including EBNAs 1 and 2 and 3, along with LMP1 and LMP2. While the Baylor Group has previously reported on the successful adoptive therapy of over 70% of PTLD patients with CTL expanded by ex vivo culture of EBV-infected lymphoblasts, the efficacy of this approach against more common lymphomas has been unknown. In the current report, they chose to focus on Hodgkin lymphoma, NK T-cell lymphoma, and diffuse large B-cell lymphoma subjects without known immune deficiency, whose tumors displayed mostly type 2 EBV latency, with expression of LMP1 and LMP2. To expand T cells specific for these antigens, autologous peripheral blood lymphocytes were cultured in vitro with autologous dendritic cells and EBV-transformed lymphoblastoid cell lines that had been infected with the recombinant adenovirus vector expressing LMP1 and or LMP2. Infusion of these CTL, which contained both CD4-positive and CD8-positive T cells, into the lymphoma patients was well tolerated. Among 29 subjects with high-risk or multiply relapsed lymphomas receiving CTL as adjuvant therapy, 92% remained in remission at a median of 3.1 months after CTL infusion. More impressively, among 21 patients receiving CTL for measurable relapsed or refractory lymphomas, 62% had clinical responses, including 52% complete responses. In most clinical and durable responders, LMP-specific T cells could be measured in the blood. Interestingly, some clinical responders also developed T cell responses to additional non-LMP lymphoma-associated antigens, demonstrating a broadening of the host anti-tumor T cell response during tumor regression. However, none of the clinical non-responder subjects tested had such spreading of the immune response to other tumor antigens. Can this technology be readily applied to lymphoma patients? Indeed, the procedures carried out here, using as little as 120 milliliters of donated blood shipped to a centralized production facility, offers that this therapy might be applied broadly to subjects with type 2 latency lymphomas in whom other existing therapies have failed. This therapy could impact a substantial number of lymphoma patients, both immunocompetent and immunodeficient, with lymphomas not curable by available therapies. These include the approximately 10% of subjects with EBV-positive diffuse large B-cell lymphoma, particularly tumors arising in the setting of chronic inflammation, and the elderly. Since 40% of Hodgkin's lymphomas harbor EBV with type 2 latency and carry a poorer than average prognosis, those not cured by conventional current combination chemotherapy might also be prime candidates for adoptive T-cell therapy targeting LMP antigens. In the current report, 4 of 8 subjects with active recurrent Hodgkin's lymphoma experienced tumor regression. What accounts for these impressive results, since the common downfall of adoptive T-cell therapies is lack of persistence of the infused cells over time? Ongoing stimulation of the T cells by EBV expressed in host memory B-cell reservoirs may contribute to their survival and continued lytic function. This has suggested that T cells engineered to recognize other tumor antigens might also benefit by starting with those naturally specific for EBV. This way, adoptively transferred T cells containing chimeric antigen receptors, in other words, T cell receptors engineered to contain antibody domains that bind to a cell surface antigen on tumors, might persist and retain cytolytic potency due to survival signals supplied by EBV in vivo. This approach is currently being explored by a number of investigators. Adoptive T-cell therapy targeting EBV-expressing cancers might be further improved by bolstering the adoptively transferred T-cell response with concurrent use of immune checkpoint blocking antibodies targeting the CTLA-4 or PD-L1 pathways that have recently been shown capable of awakening anti-tumor T-cell responses in subjects with a variety of cancers and achieving durable tumor regressions. The results of such combination studies and expanded multicenter trials utilizing this therapy are eagerly awaited. As such, the findings of Ballard et al. Constitute an important advance in the development of tumor antigen-specific cancer therapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.